So again, it's my pleasure to introduce Dr. Wahbeh, who is going to talk about top-down or step-up therapy for IBD.
Thank you, Dr. Lee, for that kind introduction. I want to thank Dr. Afzali, Madam Chair, for having us here today in IBD Horizons. I'm proud to say that I was trained in Ohio, and this is my first time back in 15 years, and it's a pleasure to be here. I'm very impressed with all the work that Dr. Afzali has done, and it was a pleasure meeting some of the IBD provider community yesterday, and I think you're surrounded by very talented and dedicated people. So thanks again for having us. So my topic today, as you heard, is looking at top-down therapy versus step-up. And to be honest, when we were drafting the agenda, we decided it's probably the last year we're going to bring up this topic because based on what we know today, top-down therapy is conventional therapy. It should be standard therapy. There should be no question about that. And I'm hoping to convince you further that that's the case after my talk today. These are my disclosures. So I'll review what we know about the natural history of IBD. I'll look at the advantages that we have when we use top-down therapy, and as you heard, top-down being an immune modulator and an anti-TNF agent, and review some challenges about top-down therapy and a practical approach to using top-down therapy today. This is known to us. We know that the majority of our patients with Crohn's disease will progress to get complicated disease, the internal penetrating and stricturing disease. And it's not to say by any means that inflammatory disease is not complicated disease. In fact, if you break down your IBD population, the majority of complicated patients will have inflammatory disease and not stricturing or penetrating. So the writing's on the wall. The majority of patients will have complicated course. And what we've learned about Crohn's disease is that as we have progression of strictures or developments of a more severe inflammation, patients go through phases where they have little to no symptomatology, and their serology markers for inflammation may not necessarily be loud and clear about the activity of the inflammation that they have. So you see progression of disease while the patient is not necessarily showing it. For ulcerative colitis, the map is more or less steady, with half of our patients doing well and the other half having active disease or receiving a colectomy. And my focus is on Crohn's disease because as much as we know we can reduce complications with cancer risk in ulcerative colitis by treating the disease, the question of top-down versus step-up therapy in ulcerative colitis has not been as well looked at as Crohn's disease. So my focus would be on Crohn's disease today. So what are the goals of therapy as we know of today, 2018? Well, we've defined remission as having our patients go through no symptoms whatsoever, have a stable body mass index, a healthy body mass index, and for children and adolescents having a normal growth and normal puberty phases, normalization of the serologies that assess inflammation, and maintaining healthy bone density or preventing rapid loss of bone density as one of the goals. And certainly having a normal productivity. Patients need to go to work, they need to go to school, and quality of life is a big target in treating our patients overall. And one of our key targets is keeping our patients steroids free, because we've learned time and again that steroids are rife with complications. And certainly we learned that getting patients to mucosal healing in Crohn's disease adds a huge value going forward. And this is perhaps how we achieve a change in the natural history. This is how we change that graph where patients go through the course of their life with Crohn's disease and end up with complications. Our traditional approach has been going from lightweight medications to heavyweight medications, from older medications to newer medications, low cost to high cost. Our approach had been more reactive. You wait until patients get a problem or get symptomatic, and then we intervene. We focus on symptoms. We don't focus on achieving targets beyond controlling symptoms. We perhaps fall into this routine of repeating partially successful therapies. Patients come in on immune modulators, they break through, sometimes they get a course of steroids, and they get back on the same immune modulators. This has been a futile cycle that patients could get stuck into time and again. And certainly the concept of top-down therapy has been labeled with no evidence that this is aggressive therapy when it should be labeled as simply effective therapy. If you look at the treatment the treatment pyramid that we have today with our options, this is what it looks like. And for the longest time, we put our money on that central box, using immune modulators to try to perhaps change a natural history for Crohn's. But this is what we've seen. When it comes to minimizing the chance of needing repeat steroid courses or moving to anti-TNFs, immune modulators, in this case thiopurines, do not fare well. You see a very flat curve. And when it comes to prevention of relapse, thiopurines also, for the majority of patients, do not do well. What about changing natural history when it comes to complications? Despite the use of immune suppression going up over the past 2 decades, the need for surgery has not budged much. So this is not much of a loud and clear statement that immune modulators can change a natural history. We have not seen that despite using them. So where can we get the positives from, or how do we get positive results from the top-down therapy? Let's see how this fares well. Well, first, we expect to see changes on the pharmacokinetics and dynamics of the anti-TNFs when they're combined with an immune modulator. And I'm sure Dr. Shevitz will educate us a little more in his talk about therapeutic drug monitoring. But we can see that combination therapy is associated with reduced immunogenicity of the anti-TNF molecule. It also reduces clearance of the drug, and we see more drug concentrations. And this has been duplicated time and again where combination therapy was used. And it's possible that combination therapy targets multiple mechanisms of action, not just the main mechanism that the anti-TNF antibodies work through. And we also know, and I'm not going to delve into that as part of my talk today, but we know that the better we get our patients into mucosal healing, complete mucosal healing, the better their quality of life is, the less frequent use of steroids they run into, and fewer hospitalizations happen. Now, the need for surgery might be reduced and perhaps more delayed than reduced, but that's not a bad goal. That's not a bad achievement. The SONIC trial taught us quite well that a combination of azathioprine and infliximab fares better than monotherapy with either agent, and that's both for steroid-free remission and for mucosal healing. This has been duplicated in ulcerative colitis in the SUCCESS trial. A combination of infliximab and azathioprine fares better than monotherapy. And Dr. Fagan also told us that adding methotrexate in the mix doesn't necessarily add a whole lot to the clinical outcome. However, as again Dr. Shevitz will educate us, you do see less antibody formation against the drug, and you see higher trough concentrations. So it takes us back to the combination therapy value using an immune modulator such as thiopurines and anti-TNFs. But I'll bring up the SONIC trial again to show this. If you look at the results here, this is the glass half empty, not half full. You look at results of remission of about 56% and mucosal healing, which is, again, is a very, very needed target and goal that we should achieve. You look at the results of 50% and 43%, and I look at these as disappointing results. If this is the best that we can get from top-down therapy, that's disappointing. However, when you look at the median duration of disease in the SONIC trial, patients came into the trial with disease for at least 2 years. And I think that's the key point here. That's 2 years of missed opportunity. When you break down the data in terms of when do you start the treatment and what you get from the combination therapy, this is what you see. In this data analysis from the adalimumab trials, the outcome here was clinical remission and mucosal healing. So this is a very strict outcome. And you see that essentially at the end of the trial at 1 year, you see a success rate of 19%, getting patients into remission and mucosal healing together. And again, 19% is quite disappointing for what you invest in that year. However, when you break it down by disease duration, you can clearly see that the fresher the Crohn's disease is, the less duration of disease, the better the results are. So again, glass half empty, because you get up to about 33% achieving mucosal healing and remission. But again, look at the duration of disease here. The cutoff here was 2 years. And again, I would put that forward as 2 years of a wasted opportunity. So many years ago, actually, the Belgian group looked at true prospective top-down therapy. And they took their patients and randomized them to receive immune modulator, Thiopurine and infliximab, within 2 weeks of their diagnosis. And back then, they were doing episodic therapy after induction, versus a group that went on step-up therapy, steroids, then adding thiopurines, and then adding infliximab. And what you see at the end of the 2-year mark, you see essentially comparable results when it comes to remission. So both groups will do well, and this is with the knowledge that the step-up therapy ends up having a lot of patients start the anti-TNF anyway. So at the end of the 2 years, similar results and comparable use of anti-TNF agents. But what was different, loud and clear different in this clinical trial, again, top-down therapy from week number 2, is that the mucosal healing rates were stunning in the top-down therapy group versus the step-up therapy. More than double the rate of mucosal healing. And this is not my focus today in terms of defining mucosal healing, but this was made pretty easy for us. Mucosal healing was the absence of any ulceration, any visible ulcer on ileocolonoscopy. So again, loud and clear results that top-down therapy does make a difference. Although it may not be visible by clinical assessment, it is visible when it comes to having no active ulceration. This is duplicated in a pediatric population. And again, 1 out of 4 patients will present in the pediatric age group. And you see in this study, similar design, essentially top-down versus step-up. And by the first year, you have an equal rate of clinical remission between the 2 groups. But again, you see almost the same identical numbers, 74% mucosal healing at 1 year compared to 42%. And again, that's with the knowledge that the step-up therapy means that a lot of patients ended up receiving the anti-TNF agent anyway. And look at the time difference here. The time difference is not 1 or 2 years. The time difference is 3 weeks of starting top-down therapy versus 8 months of escalating therapy up to the anti-TNF agent. So again, every month counts. And this is what we see from this study from Spain. Retrospectively, they looked at the timing of starting anti-TNF agents and immune modulators and the risk of surgery. And what they concluded in that paper is that for each month of delaying an anti-TNF and immune modulation, you have a 0.5% increased risk of surgery. So if you go 1 full year without starting an immune modulator and the anti-TNF, you get a 6% higher risk of surgery, and that's only for 1 year of delay. So they concluded that the window of opportunity to change a natural history, perhaps, and improve outcomes begins at the diagnosis of Crohn's. So is there a downside of top-down therapy? There is. There are risks that we should think about, whether it's allergy, infection, and we'll review the actual risk in a few slides here. We'll talk about malignancy, skin reactions, and rare incidents of neuropathy. And certainly, it's inconvenient for patients, especially when it comes to infusions. It's a cumbersome process. And of course, there's the cost issue. However, I'm focusing on what would be valuable from a patient's eyes. How do we get our patients the best results? And of course, cost is important. But if I put my patient up first, I want to look at data-driven, evidence-based value in what patients are getting. The infection question. The TREAT registry taught us that the highest risk for infection lies with prednisone and narcotics, and we should not forget the disease activity itself adds quite a bit of risk of infection. And using a biologic does add to the risk of infection. However, what we did not see is that combination therapy doesn't necessarily take that risk up higher. So using the combination therapy seems to be safe from a standpoint of infection. The more common infections are really respiratory infections, and we know that we can perhaps offset some of that risk with vaccination. And in my opinion, if you look at that one and only top infection that could be to some degree preventable, it's not a bad deal to take. But I would also remind us that there is a mortality also when we put our patients time and again, mortality increase, risk increase when we use steroids and when we use narcotics. And we know that with top-down therapy, we are better successful keeping our patients steroid-free. And if we reduce the disease activity, well, that's a lower chance of having infections. And I can tell you, as somebody who uses combination therapy in children as young as 4 years old, I do not see my patients come in with infections every other month. In fact, I see them have no more infections than the average healthy child every year. So when it comes to practical results, practice using combination therapy, even in the younger population, infection simply doesn't come up that often. Now, of course, when we are using thiopurines in combination therapy, we all know that maybe 5 up to 10% of our patients could face an adverse reaction early on, whether it's an allergy, pancreatitis, and hepatotoxicity, and changes in the blood counts. And we should do close monitoring for that, no doubt. But the majority of patients on thiopurines will tolerate that quite well. The risk of malignancy, of course, is on everybody's mind, and I think it's worthwhile to stop here and break down the actual risk that we should counsel our patients on. What we learned from the large registries in France, from the Sésame registry, is that the risk lies within the older patient group. So if you look at the thiopurine use in general, if you use thiopurines over 2 years, in individuals over 60, or younger individuals who are seronegative to EBV and CMV, the risk is actually very dependent for the majority, but not all, on these factors. And I'll focus a little bit on the hepatosplenic T-cell lymphomas. We know that these are very aggressive lymphomas. We know that they are associated with very high fatality rates. We know that for the, again, majority of patients, it seems to be EBV driven. And if you take a young male who's EBV negative and have that male be on thiopurines, that seems to be where the risk is. So if they are negative and they get exposed to the virus and seroconvert on the thiopurine. So that's one population where I would pay particular attention to that risk-benefit ratio. What we learned actually is females could also run into concerning hematophagocytic syndromes on thiopurines when they seroconvert from negative to positive, be it EBV or CMV. Now, we should also keep in mind that in the US population, beyond the age of 20, almost all of our patients are EBV positive or CMV positive. So that means there's a different risk for that individual age 25 versus that individual age 15. So I would keep that in mind. And we should also remember and tell our patients that if they use azathioprine or 6-mercaptopurine, the risk seems to be when they're using it longer than 2 years. And if the drug is continued, so if you use it, let's say, for 3 months or 6 months or a year, that risk is not quite the same. So there's that duration factor that adds quite a bit to the risk. So I'm going to talk a little bit here about the limitations of what we know about top-down therapy today. Well, there's an argument that not all patients that we learned about from the studies are real-life patients. These are not necessarily the patients that you and I see in our clinical practice. In fact, if you look at the clinical trials in adults and children, only 50% of most of our patients would fit into any clinical trial. So does this apply to community practice? I think that's a very valid question, and I'll show you what I think about that in the next slide. We actually don't have a good predictive model to tease out which patients will have an easier course or a tougher course. There's a challenge in our data that may tell us that we may be not quite reducing surgery altogether, but we may be delaying surgery. But I would put forward that delaying surgery when it's elective, I don't want to upset the surgeons here, but delaying surgery is not necessarily, delaying the need for surgery is not necessarily a bad thing. And then the last piece that I will cover is we forget about the down part of the top-down approach. We all talk about the top part, so early combination therapy, but what about weaning? And that's an important part to cover. So let's start with the limitations. So Dr. Fagan and colleagues in Canada and Europe looked at using top-down therapy in community practice. So take it out of the clinical trials, tertiary care centers, and put it in community practice. What do we see? We actually see a good delta in reduction of admissions, reduction of surgeries, and reduction of IBD-related complications. So this is real data here for how combination therapy pays off in clinical practice. What about predictive models? I got to be honest about this slide. I find it more or less useless. All these factors that predict bad prognosis, patients less than 40 years old, patients with perianal involvement, deep ulcers. I mean, we all know this. It's not worth listing on a slide. So this is to say that we certainly need predictive models to tell us not necessarily which patients will not do well, because I showed you in the first slide, the majority of our patients will move into complicated disease, and we know that inflammatory disease is not necessarily benign disease. So we all know the majority will progress to severe complicated disease. The big value here in a predictive model is predicting which patients will not have a bad course, which patients will have the 2 or 3 ulcers that will stay with those ulcers if you do perhaps nothing. These are the patients that I would love to tease out early on, and perhaps these are the patients who do not need top-down therapy. And I'm hoping that with better evolution of serologies, genetic profiling, perhaps we can get to a stage where we tell a patient with a certain phenotype and certain serology and genetic makeup that their risk of having any meaningful complication from having a few ulcers is very small, and that's the patient perhaps who does not need top-down therapy. So I'm looking forward to one day where we have that. So in my practice, and what I would propose is that combination therapy with a thiopurine and anti-TNF agent be used in moderate to severe Crohn's disease. Again, we're not talking about 3 or 4 tiny aphthous ulcers in the ileum. And certainly we have to look at older patients and younger patients who are EBV negative and CMV negative as perhaps patients at a different risk that we should maybe tip the balance and not use combination therapy in. And there's a question about whether we use the full dose of thiopurine with a study that showed perhaps that lower 6TG levels are associated with better trough levels and lower antibody levels against the TNF molecule. And again, Dr. Shevitz will educate us more about that. So perhaps we don't need the full dose of the immune modulator. I would keep in mind that the Sonic study had a full dose of azathioprine. So again, this is a moving target here. And I would actually look at a temporary use of the immune modulator. I think we may see benefit in temporary use and not needing to extend the treatment and not needing to have our patients run into that 2-year cutoff where the risk of malignancy could go up. Similarly, in ulcerative colitis for severe disease, I do start all of my patients. Again, I do treat adolescents, I do treat young adults, and I would see most of my patients get started on an immune modulator and a biologic early on. What about de-escalation? So 2 arms to de-escalating here. One arm is stopping the thiopurine. And we've seen from this study in Europe that if you do stop the immune modulator after patients being in remission on combination therapy for over 6 months, you actually see a flat line in terms of needing to receive an earlier dose of a biologic or needing to come off of the biologic. So you do not lose much efficacy if you stop the immune modulator once they're in remission after 6 months. We do see in this trial, though, that the trough levels were different. And again, we'll learn more about that shortly. You could also predict which patients will do well before you take off the thiopurine. And these are the patients with adequate trough levels, so over 5, and they seem to do much better if you stop the immune modulator versus patients who have a very low trough level. What about de-escalating by stopping the anti-TNF antibody? And this probably is worth talking about it independently in a separate presentation. But in this study from patients who have been steroid-free for over 6 months on combination therapy with thiopurine and infliximab for about a year had their infliximab discontinued, and then they were followed up for over 1 year. Actually, in the February issue of Journal of Gastroenterology and Hepatology, the 7-year data were just published last month. What we learned about de-escalating by stopping the anti-TNF antibody is that if patients are in deep remission with good trough levels, no serology markers of active inflammation, you see that top green flat line. Patients can do well by remaining on the thiopurine in that study. So there's risk involved, obviously. However, they were successfully able to stop the anti-TNF antibody. And I didn't have time to add this in my slides, but if you look at the 7-year data, the majority of patients, so 80% of patients needed to go back on infliximab. And when they went back on infliximab, 70% of them tolerated it. So in the short term, if patients break through, and you can predict it by tracking the CRP and tracking the fecal calprotectin before symptoms show up, you could actually recapture the majority with retreating with infliximab. Again, this is the 2-year data where you see 98% clinical response and 88% clinical remission and no adverse events when you restart the anti-TNF. However, at the 7-year mark, again, this drops to about 70%. So in conclusion, I hope that I have convinced you that we have now clear evidence for the effectiveness of top-down therapy, which consists of an early thiopurine and an anti-TNF antibody. And I hope that I've convinced you that we should consider a combination of these two agents for at least 6 to 12 months. And perhaps the benefit of continuing a combination therapy beyond 6 to 12 months may not be that clear. And that we can actually stratify the risk patient by patient. So we can individualize our risk profile for that patient and decide which patients are safe to get the top-down therapy because it would be more effective for them. And that de-escalation of therapy, of the combination therapy in select patients is quite possible. And I'm looking forward to hearing the talks by Dr. Fagan and Dr. Lee later today, because this is a new era where we have way more medications than we had 5 to 10 years ago. So the question is, what about positioning some of our newer biologics early on? What about a new form of combination therapy? Combination of new biologics, a combination of biologics and small molecules. The future in IBD treatment looks very exciting. Thank you.